My name is Luay Nakli. I'm a Dean of the School of Engineering and Computing here at Rice University. It's my pleasure to welcome you to the last session for today. And it is my great pleasure to moderate this session and to introduce our next keynote speaker, Dr. Krishna Udayakumar from Duke University, who's a global leader in health innovation and policy reform. Dr. Udayakumar's career embodies the intersection of medicine, business, and global health, bridging evidence, policy, and practice to improve health outcomes around the world. He's the founding director of the Duke Global Health Innovation Center, where his work focuses on advancing evidence and strategies for scaling and adapting innovative health solutions globally. He also serves as the executive director of the Innovations in Healthcare, a nonprofit co-founded by Duke University, McKinsey & Company, and the World Economic Forum. At Duke University, Dr. Udayakumar is an associate professor of global health and medicine and core faculty member of the Duke Margolis Center for Health Policy. He is also associate director for innovation at Duke Global Health Institute, where he helps shape the next generation of leaders in global health and health policy. His research has appeared in many of the world's leading journals, including the New England Journal of Medicine, Health Affairs, and Academic Medicine. But beyond academia, his insights have been featured by major media outlets, including CNN, BBC, New York Times, and many others, reflecting his influence on both scholarly and public discourse. Dr. Udayakumar is a proud graduate of the University of Virginia, where he earned his bachelor's degree with distinction and was elected to Phi Beta Kappa. He holds both an MD and an MBA from Duke University, where he was recognized as a Fuqua Scholar for academic excellence. He completed his residency in internal medicine at Duke and served as assistant chief resident at the Durham VA Medical Center before joining Duke University. Dr. Udayakumar's work continues to shape how health systems and innovations scale to meet global needs, particularly in low and middle income countries. Please join me in welcoming Dr. Krishna Udayakumar as he shares his insights with us.
Oh, and what a wonderful day it's been so far. Such a great learning opportunity and meeting so many people that are doing amazing work. So I look forward to continued engagement with all of you. What I thought we would do to end the day is really try to put some of the pieces together. And I've changed these slides probably 10 times over the course of the day as I've heard other people talk. So it might not make any sense now, but we'll give it a run. First, disclosures. We work with a lot of people in government, in foundations, in industry, and that's part of working in innovation. I'll start by reflecting on some of the data we've already heard today and talked about on what are the health challenges and opportunities, both locally and globally. How do we think about that? Second, I'll give you a few of the lessons we've learned from doing this about 15 years and understanding innovation from different contexts. And hopefully we can end with how do we frame these pieces together so that we can think about this in terms of a health systems innovation model. The way we do this work, as you heard a bit about, is a hybrid structure in itself. We have one foot inside the university where we can rely on the academic mission around research, evaluation, policy analysis, education, but we also have, in essence, an effector arm, a nonprofit we host where we can work directly with innovators. We can work with governments, with life sciences companies and others, not just to study the work, but to do the work in partnership. And for us, this is a synergistic model that's made all the difference in being able to do while we learn. Again, when we think about how to link the local and the global, many of you are familiar with data like this. This is from the Global Burden of Disease, that if you look by income categories of countries around the world, you might think that the problems we're dealing with are quite different. If you look at the US as a high-income country on the bottom right, you will see that the blue here is all non-communicable diseases. So you imagine that the greatest burden of disease is around non-communicable diseases. Whereas if you look at the places in the world, especially in sub-Saharan Africa, low-income countries where many of us work, it looks more like this top left, where it's much more red, where it's maternal, newborn child health, communicable diseases, nutrition-related health burden. And yet we know that the world is much more complicated than that. And it's often wrong answers we get when we look at aggregate data. So how do we look at the details? We know in many ways the U.S. is not a single population. And so as we get to the details of understanding how this breaks down and the disparities that we have, as well as comparisons with other high-income countries, if you look, our pregnancy-related mortality is much worse than any of the other high-income countries you might compare us to. And even within the U.S., if you look at the disparities by race or by geography, they tell a story of many different communities that we're dealing with, though especially when we talk about rural populations, which many of you have already shared your expertise in today. Of course, we've also started to talk about where in this life cycle of pregnancy and childbirth and postpartum care many of the complications arise, which you see here, and we've already started to recognize that there's a long tail of care and management that's required. We've also looked at the changing evolution of the sorts of reasons that people are having challenges, severe bleeding, infection, all the way to cardiovascular issues as well. So again, the problems when we start to break down by populations at the community level as opposed to country level start to look much more similar over time. And a common theme, whether you're working in Texas or North Carolina or in parts of Sub-Saharan Africa or South Asia, are that disparities live everywhere. You can break that down by country, you can break it down by state, you can go all the way down to zip code or neighborhood, and the disparities stand out. So really the unifying theme here is how do we develop solutions that positively impact disparities as opposed to make them worse over time. And of course, the maternal challenges translate just as much into what's happening with infant mortality. And again, you see the disparities there on the right by state. You see a twofold difference depending on where you live in terms of the risk at birth. And Texas is right about in the middle on average for where the U.S. is as well. And of course, the other thing we should think about is how the U.S. stacks up. Generally, if you look, to me, one of the most stunning graphs that I use in my teaching is the one on the left here. This is not an issue we've run into in the U.S. in the last 2 years or 5 years or 10 years. For decades and decades, we have been an outlier in terms of the value that our healthcare system generates. We spend more than twice as much per capita as any other country, and we get health outcomes that are worse than dozens of other countries around the world. You can see on the top right there, just compared to other high-income countries, our life expectancy lags by more than 4 years relative to what you would expect. And the one thing you can say is the problem is not that we're not spending enough money. If you look at the entire global economy in healthcare, it's about $10 trillion every year, of which half of the entire global economy is the U.S. healthcare delivery system. We're spending $5 trillion a year to get really mediocre outcomes, and that's what should really be frustrating to all of us in this room. And that's the opportunity we have. As I mentioned, what ties this together is really that we're sharing the same challenges. The health challenges and the disparities look similar, whether you're working locally or globally, as do the financial challenges over time. Right now, we're dealing with fiscal pressures in the U.S., changes to Medicaid and other payment systems over time where we're having to figure out how to do more with less. It turns out if you're one of these countries in Sub-Saharan Africa that have relied on aid as the anchor point to delivering health services, you're in just as much, if not more, trouble right now. On the right-hand side, you see the projected changes to foreign aid over the coming 2 to 3 years. The U.S., we're losing about 60% of where we started from last year. But again, this is not an American phenomenon. Every country in Europe is also pulling back on foreign aid because they're having to deal with challenges locally, including the war in Ukraine. And what's happened in Sub-Saharan Africa is what you see on the other graph on the left-hand side. The debt crisis is underappreciated in terms of what the countries are dealing with. There are now 1 billion people that live in Africa whose governments are paying more every year to service their national debt than they're paying for the entirety of their health systems. and it's getting worse, not better. So we're dealing, on one hand, with challenges that continue wherever you are with health and healthcare. The fiscal pressures are very real and getting worse in almost every country in the world. And then you turn to the other side of the equation of what many of us do every day, which is get up and think of new solutions and take them to market and figure out how to improve people's lives. So the good news part of this thread is the pipeline of innovation is as strong as it has ever been and continuing to grow. This is a review by Impact Global Health on just innovations that are being developed for pregnancy-specific conditions across drugs, biologics, devices, and more. And you'll see that that x-axis goes up over 300. So more than 300 innovations being developed right now for preterm labor and birth. The same for preeclampsia and eclampsia, more and more over time. And this is data that we've just pulled together ourselves, which is looking just at the late-stage pipeline. So everything that in regulated health product development is beyond phase 2. And if we look at HIV, TB, malaria, maternal, newborn, and child health, that's almost 300 new health products that are in advanced development or approved already in some countries, waiting to be introduced in others. Now, if you put that together, we've got countries that are struggling to deliver essential health services, that have worsening fiscal crises, and yet piling up at the door are more and more innovations that could have tremendous impact on health, on lives, and economies. And this is what the delivery system statistics look like. This is data that we published earlier this year looking at the end-to-end research, development, introduction, and scale-up of health products for different disease areas and different populations and different product categories. That on average, it takes 13 and a half years from ideation to achieve even 20% uptake. And we had to stop counting at 20% uptake in low and middle income countries because almost no health product has data showing 50% or 80% uptake for intended populations. We can talk about scale all we want, but historically, almost no product has achieved scale in any lower middle income country. And that's the reality that we're facing today. So that's the context of where we find ourselves. First, that pipeline of innovation, incredibly robust. Decades of investment of tens of billions of dollars are paying off. The amazing work we've been hearing about today is what we should be celebrating, except now we've got to say, what comes next? Uptake remains slow. Delivery systems are not fit for purpose. The ways that countries are making decisions about what products to introduce or not aren't rational. And at the same time, there are fiscal pressures where people are taking money away from health systems, not adding to them. And in that environment, the challenge to all of us is that we have to continue to innovate. And in fact, innovation is the only way we get out of this situation. So we can talk about efficiency. We must absolutely be efficient. Every dollar has to go as far as possible. But we also have to talk about effectiveness. Things have to work, but not only that, part of effectiveness has to be fair access. It has to be equity. And that is the core tension in the field right now. I can achieve scale much more effectively if I leave vulnerable people behind. And yet, that's what we've done historically with almost any new technology, including what we're seeing with big tech, with AI and others. The technology without design for equity will actually make things worse, not better on that front. So how do we do this? Well, I would argue we got to start studying what's happening not just in places like this, even though it can't compete with the skyline that you've got here, but this is the Duke Medical Center. We've got to start learning from places like this, which is rural Kenya. And we've got to be able to learn from both of those. So some of the lessons we've collected along the way, we've thought about innovation in different ways. First is we really like working with startups, with social enterprises. And it's because they have to be focused, right? Many of us do research. We show all sorts of interventions can be efficacious or effective, and then they sit in a paper. We develop lots of products that have product characteristics that are advantageous and don't go anywhere. But if you're running a business, you've got to have a product or a service that works, but that's not enough. You've actually got to have a business model around it to figure out who are your customers, what is your market, how are you going to compete. And that's why we really have spent more than a decade studying what's happening in terms of startups in health and healthcare in low and middle income countries. Given the fiscal pressures that we're all facing, we've also started to look at this issue around how would you develop a field around frugal innovation? If we had to do more with less, how would you approach that? And third, we already heard about some of the wonderful work that's happening around population health and value-based care. So we've looked at that issue. Again, not an American model only, but the ideas and principles around value are ones that cut across the world too. As I mentioned, through our nonprofit, we now have a network of more than 100 growth stage health startups that are operating in almost 100 countries. They do everything from care delivery to technology development, and especially in the digital arena, looking at financing like microinsurance programs, infrastructure, workforce models. Just a couple of examples. And this picture on the top left is from an organization called Medical Home. They operate in Mexico. And it's actually a joint venture between the largest telecommunications company in Mexico and a telemarketing firm. So it's a health solution that has nothing to do with the healthcare delivery system. And they offer a subscription $5 a month where you and your family can call in and talk to a doctor or a nutritionist or another health provider 24 hours a day. They've done this more than 10 million times. They've been able to answer not just a triage question, but actual health advice more than 60% of the time without referring to a facility. And now they're operating in the US through a sister company where they're able to work with Spanish-speaking populations that otherwise can't access language and culturally competent care to be able to navigate a growingly complex health system here in the US. And on the bottom right is an organization called Jacaranda Health that started in Kenya and started off by building and operating maternity care hospitals, trying to solve this issue around high-quality, low-cost maternity care. And then they added a layer where they took the lessons learned and pushed them into the public sector. And now they've added a layer of technology development. So they have an AI-driven platform called Prompts that's now active in multiple countries where there's an AI chatbot, essentially, that guides women through their pregnancy with health advice. So amazing work that's happening, and work that's happening because it's in low resource settings. And a lot of our work is grounded on a recognition that many of the most transformative and creative solutions are happening in the places where the problems are most real and urgent, and the resource constraints are driving better and more transformative solutions. And when we've looked at dozens and dozens of organizations, here are some of the things that come through. None of these are rocket science, and many of them you've heard from the speakers today already. First, it's got to be about the consumer, the patient, the beneficiary. Who are you serving? What do they need? And how do you embed yourself into their established behavior patterns? If I've got a health question on a Friday evening, I'd rather call and talk to a doctor than make an appointment for 6 days later and have to drive myself somewhere. Second, thinking about digital as a digital first strategy, not a digital later. The most ubiquitous technology in the world right now is the mobile phone. So if you were to design a health system from scratch, you would not start with a hospital. You would start with an individual, a family unit with a mobile phone. And only when you ran out of things that you could push through a phone in terms of health advice and health-seeking behavior would you say, let me now send a community health worker to your home. And only when you ran out of options, and only at the very last option would you think about building a hospital. And that's what innovators have been doing over and over. Third, it's about the workforce. We've talked about this quite a bit today, about both building capacity of the workforce, but more and more recognizing that the workforce of the future has to look completely different. We're not going to solve this problem by training more doctors and more nurses. So how do we think about lay health workers, community health workers? How do we bring people into the health workforce that wouldn't otherwise be part of it? Fourth, how do we learn from other industries about the value of standardization and the ways that it not just creates efficiency, but by reducing variability, improves customer service and improves quality over time? Fifth, we've got to figure out what to do around capital expenditures in the health sector. So how do you think about asset-light business models by leveraging existing infrastructure much more effectively? And then finally, a lot of what you're doing already is unlocking the power of data. How do we capture better data? How do we use it more effectively in real time? And how do we feed that back to the people that can make better health decisions because of it? Again, this idea of frugal innovation, we didn't quantify it because we're not that smart, but we said, how do we define it? It's doing more with less for many. And we started to look at thousands of potential examples, honed in with colleagues from Imperial College London on a series of case studies that we did. And what did we take from that? Again, not rocket science, but hard to execute consistently. If you want to reduce the costs of care, you've got to change the settings of care and the providers of care. It can't be in fancy hospitals. It can't be about expensive equipment. And it can't be about highly trained physicians as the primary delivery mechanism. Second, most of our health systems are not systems at all. If we could reduce the friction, if we could actually solve the challenges in communication and coordination, we could take a lot of the cost out of the system and actually improve the patient experience. When I talk to a lot of domestic audiences, I point out that there are 3 fields that had negative workforce productivity, labor productivity over 20 years. Performing arts, you're not going to make that more efficient. Higher education, and healthcare in the US. And in our technology investments in the US, we've invested more than $1 trillion into information technology without actually improving productivity. That's an insane way to think about what we've done here. We just keep adding layers and layers and layers as opposed to creating efficiency. And then how do you move upstream? It can't be about acute care delivery. It's got to be much more about health-seeking behavior and prevention. And what we learned from all of the organizations we studied is the importance of leadership, something all of you embody and what we heard about, that you've got to have really strong leadership both at the top as well as the front lines for change management to work. One of the things we did a few years ago is we took about a dozen senior leaders in the health sector from the UK and from the US, and we took them to India for a week. We said, we can tell you these case studies, we can show you slides, but you got to be there, you got to breathe it. And we took them around and showed them many of these institutions that we've been talking about. And the group from the UK came back and wrote this report of how do they adapt into the NHS the principles of frugal innovation. And the first thing they said was, we have to make efficiency a noble purpose. It can't be that I'm a doctor and I want what's best for my patient and the administrator wants to cut costs. No. At the end of the day, we're trying to serve the same people, and efficiency is what makes this noble. Second, we've got to get way better at harnessing everything around us, our community resources especially. And we've got to put a system and a process in place where we keep getting better. And finally, it's got to be demand-based. We've got to listen to the people we're trying to serve. And then the third way we've been trying to think about this is this whole idea of value-based care, right? Accountable care, value-based care. We've worked on it in the US, but it's of course not just a US phenomenon. And we showed that by looking at low-income, middle-income, and other high-income countries that have put those principles in place. And what we took away from all of that is that our health systems have to change in the way we design and implement them if we're going to do this well. If innovation is going to serve a purpose where we're not just optimizing a product, where we're not optimizing a microenvironment, a single point of care. If innovation is going to come together effectively, our health systems have to be designed much more like what you see on the right-hand side. Right now, our systems are disconnected. They're not actually integrated in any way. So how do we get to this idea of a person-centered, integrated model of care? And that's what we've been trying to talk about as the way forward with person-centered, integrated innovation. And that means point solutions, as I would call them, are important. The new technology, the new device is incredibly important. That is the core of invention and innovation. And yet it doesn't solve a complex health challenges at a population level. And that's what ultimately is the problem we're trying to solve. So how do you couple a workforce model with the right technology, with the right data systems, with the right physical infrastructure? It all has to come together for it to be an actual integrated innovation. And it can't just be trying to solve one thing. It has to actually solve the entirety of the continuum of care. Turns out even that's not enough, because if you're going to make it sustainable, if you're going to make it equitable, if you're going to make it scalable, you have to get the policy environment right. You've got to figure out financing from both public and private sectors from the beginning to make this sustainable. And you've got to build the system capabilities for this all to work. Now, one way we're trying to put this into practice, I'll just briefly touch on, and happy to go into more detail if useful. We've partnered with the governments of Kenya, Senegal, and South Africa. Again, governments that are struggling to make key decisions right now about innovation, and taking all of this evidence to say we will help and empower country governments to become more effective at making whole-of-government coordinated decisions about how they prioritize and implement innovation. We will help them unlock the data they need for better real-time decision-making. We will create whole-of-market platforms where they can work with the public and the private sector together with civil society and others. And finally, we got to stop thinking about solving problems with single products. So how do we think about a portfolio mindset? Again, it's something that the program here has really been at the forefront of already doing for many years, but how do we make that the standard? And the last thing I'll talk about is an issue that's come up a couple of times, and one that I think is at the core of all of this. It doesn't matter how good our innovations are if people don't want them, if people don't accept them. At the core is the issue of trust in science, trust in health, trust in public health, which has been declining for decades and now continues to worsen. We've just launched a US-based program, a national platform called Healthier Together, where we're trying to build the next generation grassroots health communications network as a mechanism that, with an initial focus on rural America, is trying to build on the existing trusted relationships at the community level, give those trusted messengers the resources, the peer networks that they need to then ensure that the people that trust them are able to make better health decisions for themselves and their loved ones. So with that, hopefully, it's an optimistic way to move into this, that we really need to start thinking about the way that we can transform policy, payment, as well as delivery systems, and that whether you're going to work locally or in a different part of the world, understanding what's happening in different contexts in different countries is incredibly important to do this well. And those governments and organizations, like what you've built here at Rice, are exactly the types of organizations we need that can systematically lead the field forward. So thank you. I look forward to the conversation.
So you mentioned AI chatbots.
Yeah.
You mentioned digital health. And you were talking about health disparities and all of that. So then there is something interesting there, that when we think about AI and digital, there are two big challenges there that can be big contributors to disparities. One is we can have a gap, and a widening gap, between those who can develop and use them and those who don't or cannot afford them. The second thing is, of course, biases in data and all of that.
Yeah.
So we are trying to solve disparity issues with technology that also is contributing sometimes to disparity as well as to widening the gap. So what are your thoughts about that?
No, thank you, and you're exactly right. I think that's one of the core questions of our time. And I look at this like any technology can be applied in ways that improve disparities or worsen disparities. And AI, because of the scalable nature of the technology, I think is just outsized in the ways that it can impact it. So if we were to do this well, we would see frontline communities in rural parts of the world, including the US, but also Africa and Asia and Latin America, where right now they have almost no access to healthcare. And yet, if you coupled a community health worker with the ability to access AI-driven solutions, you could actually empower them and upskill them to be able to offer much greater health services than is available today. Or you could do this in ways that contributes to biased data being available and poor solutions that are put in place as alternatives to doing the right thing. So I think the evidence is not in yet as to where this is going. So we've just launched a new initiative on AI and global health, and it's really trying to look at three things, beyond the technology itself. First, what is the evidence that it works? Right now, most solutions being developed and implemented in health settings around the world do not have evidence of any outcomes. So are we actually developing a strong enough evidence base for the application of AI tools? Second, what are the best practices and principles for safe and responsible and ethical use of AI? Almost no country in the world has mature policies and regulations in place, including the US. And there's already tension between what the US is doing, what Europeans are doing in terms of how to regulate AI. We've done a study of, I think, 70 countries so far looking at national AI policies, and almost none of them are ready to actually be able to create the right safeguards. So how do we help move that along more effectively? And then the third, what's the model for sustainability? There's a lot of venture capital going in, there's philanthropy going in, there's some governments investing. Nobody's figured out how you make this sustainable in ways that can actually be embedded into especially public health systems, which are going to be needed to address some of the disparities that exist at baseline. So we think those are some of the big questions to be answered, and it's certainly an open question as to what the role is going to be.
Thank you so much, Krishna. I will take questions from the audience, and I see Rebecca already lined up there.
Thank you so much for a really great talk. You talked about the importance of taking a systems approach for developing and maximizing the capability of innovation. And my question is, how do you accelerate that? How do you nucleate that? And how do you get the pieces more aligned so that, like if you're, for example, a technology developer, you don't just hear from investors, oh, you need to engineer in a consumable so you can,
Right.
have more profit for the company, but yet make it less sustainable. How do we do a better job of building those systems approaches?
Yeah, no, thank you. That's a tough question. It's got so many moving parts. One of the things that we've started to work on is could you create a repeatable process in the same way that we now have decades of experience around improvement science, and we know that the PDSA cycle as a core aspect of improvement science. Is there in the growing field of innovation science a similar pathway? And part of what we've landed on is a repeatable cycle that starts very much with the first phase of problem sourcing, right? It's very familiar to design philosophy, but how do you understand the problems at the level of the people that you're trying to solve them for, but also the system, right? So you have to understand, if we're talking about maternal mortality, maybe it's around postpartum hemorrhage. So what are the issues around postpartum hemorrhage, but also what is the system that's needed to address that challenge? So many of which we've talked about here. So if we're able to understand at two levels, then I think there's a second phase, which is this idea of innovation scouting. So it's not always going out and inventing the next thing. It's actually understanding what's available locally, regionally, globally. And I would argue this local to global is really important to understand what's being developed elsewhere. If I want the best phone, I don't go to just say, well, what's being invented in Texas right now for my phone? And yet for healthcare, we do that. So how do we get more comfortable that it's a global marketplace of ideas, of products when we're trying to address health challenges? And then the third part is, this is where the messy part is around integration. So how do you design an integrated delivery model? So how do you take that technology and figure out what's the right workforce model you need for it? And how do you now put some sort of financing model behind it, so that you're not getting 2 years later saying, I've got a fantastic product, I just proved all the technical specifications, and yet it doesn't have a proven use case. So it's moving upstream as much as possible in that process. And I'd say the challenge is to not put up roadblocks to people that are in the early stages of innovation. In the same way that in biomedical science, we need discovery science, we need innovation, we need invention to be happening in real time. It's how do we move upstream as much as we can, the guidance of that innovation process to be about practical and integrated solutions.
Thank you.
Thank you, Krishna. Next question.
Hi, thanks. That was really thought-provoking. So my question is, so if you think about something like mobile banking, right, in sub-Saharan Africa, that really leapfrogged the whole like institutional bank. And you kind of said if we were rethinking healthcare, we'd start from the phone. So I guess my question is, from all of your work, have you seen maybe a specific geography or a specific technology where you see that same trend and you think that's going to happen, where we're going to be leapfrogged fully?
Yeah, thank you. I'd say maybe two things. I'd say one, building exactly on your example of mobile banking, if we look at Kenya and M-Pesa, where 85% of the adult population has mobile money, has no connection to a bank, there are enormous benefits to health that you can build on top of that. You can create health wallets. You can create behavioral economic incentives that say you can use this money that's in your digital health wallet if you are following health-seeking behaviors, but that's what is required to unlock it. And you can use that as an incentives all the way out to the supply side as well, to say your facility can be paid with this health wallet dollar if you meet quality standards. So now you can start to set the bar higher and higher over time, where you're actually influencing both the supply and demand side of the health system purely because you're leveraging a digital technology that is at its core at the infrastructure. If you look at China, my goodness, if you look at some of the digital platforms that have 200 million users, they're able to drive their own health systems because of that. Ping An as one example, and Ping An Good Doctor as the health system they developed out of it because they have an aggregated consumer base. The other thing I'd say is the conversations we're having with a lot of governments is to shift the conversation from a woe is us, we don't have enough hospitals, to thank goodness we didn't build all those hospitals 20 years ago when people told us to, because that's not the health system of the future. How do we actually leapfrog the systems that we are struggling with in the US, that the UK is struggling with, and others that are grounded on facilities that are decades old, to say we're going to actually design our health system to be digital first, which will certainly require facilities. People will always get sick, but that can't be the basis of creating new health systems.
Maria?
Sure, thank you. I guess I'm trying to think of how to word this in a positive way. We all know that innovation does cost resources somewhere. And in a US setting right now, we heard in Texas where 50% of the counties are maternal health deserts. So we aren't even providing with the resources we have the most basic of care. What are sort of new resources that could be used to develop innovations that could really drive change in those environments? Have you seen anything that's new and different? I think even traditionally in a healthcare setting, right, insurance and either private insurance or public insurance pays. I've been thinking a lot about USAID. That money isn't there internationally. Right. Maybe there's some great things that'll come from that. Maybe there's some real challenges. But I guess I'm just thinking about, like, we've gotten to what we heard today, which was even the most basic things aren't getting paid for. So how do we find unique sources of resources to do the kinds of things you're talking about where we could leapfrog? Because even with leapfrogging, we need to spend some resources, money, to get there. So I'd love to hear what your thoughts are.
So I think, one, the transition almost always requires some slack in the system, whether it's time of people or money, until you can start to create more financial accountability. So change requires that slack, for sure. I'd say the good news is, when we're thinking about change in the US. We're starting from a system that spends on per capita almost $15,000 per person today versus sub-Saharan Africa where that average is $80 per person per year, right? So again, orders of magnitude different. The challenge is how do you unlock some of those resources that are used incredibly ineffectively right now? And that's an issue that is going to require change that's frankly not going to come at the national level. What I'm more and more optimistic about is, as has always been the case, the states are going to be the platforms for innovation, whether it's around Medicaid waivers or Medicaid expansion or other opportunities that states take, or even in ways that are smaller than states, whether that's the county or other regional levels. We're seeing a huge amount of innovation happening, some of which we already heard about today. I mean, amazing work that Driscoll and others are doing by figuring out how to work within the system. And I think what we have to do is to be accountable in the outcomes we expect and be much more flexible in how you get there. If you're going to over-regulate a field as to you have to use this type of widget in this type of facility and now you have to do something different, I think that's the inherent tension is you can't regulate inputs and expect changes to outputs over time. And so how do we convince people that what we're asking for is not more money, it's actually the flexibility to deliver better outcomes with the same money? And I think there are places to learn from that are doing this fairly well here in the US.
Do you feel that this slow time or the long time it takes from innovation to adoption has something to do with the fact that we are not utilizing the power of the humanities and the social sciences and so on? We can think about engineers and scientists developing the solution, but understanding the culture, telling the story and all of that requires people with different skills.
Yeah.
Are they incorporated in this system? And do you think that is, if they are not, do you think that is contributing to that slow, or long time from the development to the adoption?
Without a doubt, I think it's contributing in almost every country to whether it's the speed or the fairness of access or all the other issues that we deal with, and that I'm spending more and more time at Duke with my humanities colleagues, trying to learn from them, because understanding context, understanding history is incredibly important to doing this right. And we have positive examples to deal with. The slide that said it takes 13 years also said when we get serious about something, we can do it. In the midst of COVID, if you look at the development, the introduction, and actual global scale of vaccines, we did incredible work because there was a very clear goal that was existential, not just in Africa. It was an existential crisis to every country. Money didn't matter. You could throw tens of billions of dollars at a problem, and we've started to break down those rules that kept us from doing good work. The public and private sector could work more effectively together. We could address some of the regulatory challenges. But the places where it broke down are places where exactly people didn't trust vaccines. Even in the midst of a pandemic, people didn't trust vaccines. And I think what we're dealing with now in terms of lack of trust had to do with not the breakdown in science, but the breakdown in trust, that many people felt like they didn't get the best of public health in terms of changing issues around masking, about kids being out of school, all of the things. And how do you have enough of a reckoning that people can start to rebuild trust, as opposed to it being seen as a way to divide people going forward? And I think the way we're going to fix this is to go back to the social sciences and the behavioral sciences much more than it is to keep publishing papers and showing how good the science is.